I use she, her pronouns, and I'm the managing director for health systems at Share Strength, one of the co-designers of the Medicaid Food Security Network. I want to welcome everybody to our webinar today. While we're waiting for everyone to join us from the Zoom chat, please put in your name and pronouns, your organization and title and your role. If you are a member of the steering committee, please let us know that as well. And if you're one of our guest speakers today, welcome to you as well. And go ahead and signpost that to everyone. Beth, thank you for kicking us off. And in addition to who you are and any ties to the Medicaid Food Security Network, if you have a burning question or thought that you're bringing to the meeting today, we'd love to hear it. So welcome. I'm going to do a little bit of housekeeping as people trickle in, and then we'll get started. We have an amazing webinar for you today, and I'm so excited to share more about what that looks like. Next slide, please. Great. I want to just remind everyone, this is a Zoom recording. We record for the benefit of those who may have registered or wanted to participate, but couldn't make it here today. And we always post our Zoom recordings on the Medicaid Food Security website. One of the great things about this network is that the dialogue and resource sharing is so active. And so for that reason, we use the meeting. We're in a meeting setting, not a webinar setting. So please be sure to use the chat feature. Feel free to submit questions throughout the chat. We have people who will do their best to either respond in real time or and we encourage network members to chime in as well. And anything that we don't get to, we can follow up on. But then I also want to ask everyone to make sure that you are muted because we want to keep this chat feature active. That means that we're not in a Zoom setting where we can control everyone's noise. So that's your one task to do today as well. So great. Thank you, everybody. Next slide, please. I want to just briefly cover our meeting objectives for everyone today. Our goals here today are to increase awareness of some of the new resources in the field available to supporting partnering with Medicaid to address food and nutrition security. And then we're going to do some quick and really exciting highlights of different new resources. And then we will delve into a more engaged conversation centered on how community health workers can support addressing food and nutrition security through Medicaid, including what are some of the barriers and what are some of the opportunities there. And we have special guests for that, and really appreciate Nashua being here to help us with that today. And then as part of our ongoing effort to foster collaboration and engagement across the network, we are also going to be spending time in some really dynamic breakout sessions with some of the resource presenters. And we'll take notes, share those out, and really try to hone in on some more useful and intimate dialogue around the resources we're talking about today. Next slide, please. So much housekeeping. So just so that you can pace yourself, we're just going to cover the welcomes and introductions, and then we'll get to partner updates. We'll spend about 40 minutes on that. Breakout discussions, we really invest time here so that you can get the most out of getting your burning questions and your ideas asked and answered and shared. And then we will wrap up with some closing remarks. Next slide, please. We know that we see a lot of people return for our quarterly network webinars, but we also hope we're welcoming some new people here today as well. And so just as a brief refresher, the Medicaid Food Security Network is a group of healthcare and food security stakeholders mobilizing Medicaid systems to become a key partner in addressing food and nutrition security, with an emphasis on closing enrollment gap in SNAP and WIC. We have roughly 500 members representing all 50 states. I hope if you're joining us for the first time that you really dig in to some of these resources and to the active network, and check out the website as well to use our policy dashboard, our news digests, and our promising strategies guidance. In addition to the mission and vision that you can see here, I'll just, as a reminder for any new participants, remind everyone that our goal here with the Medicaid Food Security Network is not to ever duplicate some of the exciting efforts that are happening in the field. In fact, we exist to convene and collaborate some of the expertise in the field and the practitioners who are looking for ways to partner with Medicaid to address food and nutrition security, especially as it relates to closing SNAP and WIC gaps. And we do this through forums like this, and also through current resources and activities that we have on our website. So the Medicaid Food Security Policy Dashboard is a great place to visit in order to see examples of how other states are currently leveraging opportunities within Medicaid to address food insecurity. And we have a Medicaid video series called Medicaid 101, so that you can understand if you're just interested and wanting to learn more about how you can develop a journey possibly in your state around partnering more with Medicaid. And then we do disseminate a bi-monthly news digest. I hope everybody received their edition. I think it went out last Friday, but of course that is also always posted on the website, as is the other, the backlog of our other news digests as well. And then one of the key objectives of the Medicaid Food Security Network is to really help states accelerate the policy change that they have decided will be valuable to address food and nutrition security. And so we do that through our Medicaid Food Security Partners program and through some really wonderful and active TA opportunities with additional states. To date, we have worked with 7 states and helping them connect to resources and identify plausible paths forwards based on the entire, other networks' successes. So thank you for that. Next slide, please. Okay, and now we're gonna jump right in because we have a number of great new resources to spotlight. So I'm going to pass things over to Katie Garfield from the Center for Health Law and Policy Innovation.
Hi, thank you, Colleen, and thank you for giving me this opportunity to spotlight our new resource. I think it's really in line with the goals of this group and hopefully many folks on the call. So today I'm going to be talking about a new toolkit that our center released this summer in partnership with the Food is Medicine Coalition. And I'm just dropping FIMIC's website since I know they couldn't be here today, so I'll let them introduce themselves electronically in that way. But they are a national coalition of nonprofit organizations that provide medically tailored meals and groceries, as well as medical nutrition therapy and nutrition counseling to people in communities across the country. And our center is a center of Harvard Law School that really focuses on advancing policies related to chronic illness, and my particular work focuses on policies that better equip the U.S. healthcare system to address health-related social needs, including food and nutrition security. And so what this toolkit really is designed to do is to provide a roadmap for state officials who are trying to understand their options to use Medicaid dollars to provide food as medicine interventions. So things like medically tailored meals, medically tailored groceries, produce prescription, food pharmacy, all of those interventions to Medicaid enrollees. And importantly, for the purposes of the toolkit, we really define that big bucket of food as medicine interventions as really those services that include the direct provision of healthy foods through the healthcare system. And today I'm just going to give a really brief overview of the toolkit, its goals, and its contents. If you'd like more detail, the actual link to the toolkit is on this slide. I'll also drop it in the chat. It can be found there. Okay, so next slide. So our goal really in developing this toolkit was to flesh out some really helpful recent guidance that CMS made available and try and make that guidance as actionable as possible for states across the country. So to sort of back up, as many of you likely know, the Centers for Medicare and Medicaid Services, which leads our Medicare and Medicaid programs across the country, released an extremely helpful piece of guidance, really in the form of a chart, back in November 2023. And I'll drop that chart in the chat because everyone should be aware of it. It's great. Well, I want to do it. Sorry. Try again. There we go. So they released this very helpful chart back in November 2023 that provided a lot of new insight and guardrails regarding the legal levers, or what I'll call authorities, that states can use to support the provision of nutrition and housing supports in Medicaid and CHIP. I'm mostly focusing here on the nutrition supports part of it, but it's really important to acknowledge that housing supports have also been a major part of this effort, and they're covered in that CMS guidance. So if you're interested in housing as well, I would check out that link. In the guidance, CMS explains that states have the option to use 4 main authorities to pay for and deliver select food as medicine services. And those authorities are really Section 1115 demonstration waivers, home and community-based services authorities, in lieu of services authority for states with Medicaid managed care, and then CHIP health service initiatives. And our toolkit really analyzes and details the law and policy underpinning those authorities. So saying, okay, why can states do this? What would they cite to do this? As well as their application and approval processes. The toolkit also contains helpful implementation examples throughout, and a section at the very end that really examines the practical policy and implementation considerations that might have implications across any of these options. Essentially, what should a state be thinking about if they're going to go down this road? And throughout the toolkit, we compare those 4 policy pathways across 5 main characteristics, which I would describe as like 5 main decisions a state might have to make if they were looking to use one of these pathways to pay for nutrition supports. So first, what nutrition supports are actually allowed under each authority? Which populations can you reach? So who can you get those supports to? What is the initial approval period? So really, how long does that authority last until you might have to renew it? Fourth, fiscal requirements. So some of these have sort of fiscal guardrails via federal regulations that states need to be aware of. And then finally, what are your evaluation requirements? A lot of these pathways include the requirement for states to sort of evaluate the impact of doing this to understand whether or not it should continue and in what way. So next slide. So as you all are probably more than familiar, it's important to note that these authorities are used for much more than implementation of nutrition supports and food as medicine, and even much more than health-related social needs services writ large. These are really broad authorities that state Medicaid programs use for a whole variety of initiatives. However, we're really limiting our discussion today and the toolkit really to how they can be used to advance nutrition. And so just as a quick reminder for anyone for whom the authorities are new, here's a brief definition of each on the slide. So first we have section 1115 demonstrations. These are in the news a lot right now. These are large waivers that authorize states to temporarily modify their Medicaid programs with CMS approval through experimental pilot or demonstration projects that are focused on promoting the objectives of the Medicaid program. So very broad, very flexible. Next, we have home and community-based services authorities. These are really authorities that authorize states to provide eligible individuals services in their home or community rather than through institutional settings. So these are really authorities that are meant to keep people in their homes and out of places like nursing homes when they're receiving their care and living. And then we have in lieu of services, or ILOS, which is an authority that enables states to authorize Medicaid managed care organizations, so health plans that contract with the state to provide Medicaid services. This ILOS authority allows those plans to provide medically appropriate, cost-effective substitutes for traditional state plan covered services, and then CHIP health services initiatives, which enables states to provide direct services and develop public health initiatives that directly improve the health of low-income children age 19 and below who are eligible for CHIP and or Medicaid. And so I'll just take us really briefly. You can dig into the actual report to see more, but I just want to give you a sense of the types of things that are covered. So first, we talk a lot about the nutrition services that are allowed under each authority. As you may know, CMS's November 2023 guidance details 5 different services that can be governed based on the robust evidence that's out there. These are case management, nutrition counseling, meals or pantry stocking, nutrition prescriptions, and grocery provision. As you can see from the chart, they're really available across the authorities, but the exact limitations around them may differ depending on which authority we're talking about. So you'll see, for example, with meals, there are some limitations on home and community-based services and ILOS that make it so we can really only provide 2 meals per day as opposed to a full nutritional regimen under those authorities. And states can go beyond these, but in those cases, they have to propose them and get CMS approval, and it may take a little bit longer. CMS has to approve these as well, but it sort of blessed these through the guidance. And so the expectation is the CMS approval of the ones that are described here will probably be quicker than if the state goes beyond these categories. Next, we talk about populations reached. As you can see, next slide. On the left-hand side here, there's a summary of the populations that each authority can be used to reach. However, we try to also provide some helpful visuals to kind of help you understand the relationship between these different authorities and how the populations differ. So for example, in the diagram on the side, you can really see how we think about section 1115 as very much the broadest ranging authority. But then within that, we have some other authorities that can reach slightly narrower populations like 1915I, home and community-based services, state plan options, and then the narrowest, 1915C, home and community-based services waivers. Next slide. We also talk a lot about the application and approval processes and the sort of overall approval periods. So those processes can vary considerably across pathways. And some of them, it's important to note, some of these authorities may institute permanent changes to a state's Medicaid program, while some of them are temporary and need to be essentially re-upped every couple of years. And so those are things we compare across pathways. We also talk about fiscal requirements. I'll note that CMS has really been doing a lot of work to make some of the most difficult fiscal requirements of complying with these payment authorities more manageable. But despite these changes, states determining whether to submit, say, an 1115 demonstration application, a home and community-based services application, approve in lieu of service, or otherwise pursue one of these pathways, will need to consider the existing fiscal implications when they're sort of planning out what they'd like to do and the budgeting implications here. And so we talk a lot about that. And then next slide. Finally, we also talk about evaluation. As you can see from this chart, which is also in the toolkit, there are some evaluation requirements really across these pathways, but they do differ slightly. The other important thing to know is that CMS has also put out some really helpful resources to sort of guide evaluation in this space. And so we try to lift those up and make those accessible as possible to the reader. And then finally, last slide, we have a section on considerations. And this is really recognizing that there's only so much that we can tell states just based on the letter of the law. So much of this needs to be looking at the experiences of states that are already out there, the experiences of nutrition organizations that have interacted with those states, and really understanding what may be the practical barriers and practical considerations that a state may want to consider as they move forward from the proposal to implementation. So thinking about things like fiscal considerations, program criteria, healthcare and infrastructure coordination, and service delivery. And we've outlined a number of categories there. So that's just a really quick overview. I hope you check out the toolkit itself. And next, I'm going to go ahead and pass it to Enrique at the Association for Community Affiliated Plans. And I'm happy to answer a couple questions in the chat if you have any. But to keep us on time, I'll pass it over.
Great. Thanks, Katie. Good morning, good afternoon, wherever you are in the country today. So I'm Enrique Martinez Vidal. I'm the Vice President for Quality and Operations at ACAP. If you want, and first let me thank the Medicaid Food Security Network for inviting me to present on some of our SDOH benchmark assessment findings. And I'll tell you a little bit more about that in a minute. But first, thank you, Katie. That was really a great sort of setting what the landscape is, which is within where our plans have to operate. So that was really helpful. So I'm going to dive down a little bit more granularly on what our plans are doing to address the social needs of their members. So if we can go to the next slide, just a little bit more about ACAP. We are a national trade association. We have 81 member plans across the country, representing almost 30 million people. They all have to be nonprofit and have at least 51% of their members in the public programs. And they all have Medicaid contracts in their respective states. Some are in Medicare with the dual, some are in marketplaces. And they're really all mission-driven plans. And while our organization does a lot of advocacy work at the federal level, not so much at the state level, my job is to work with the plans themselves, supporting them on quality improvement, operational improvement, and that includes all their work on trying to address health disparities, health equity, as well as their work to address the social needs of their members. So if we can go to the next slide, I'll talk about the SDOH benchmark assessment. So over the past few years, we've been doing a lot more work with our plans on SDOH or health-related social needs, whatever acronym you want to use these days. Our plans were doing a lot of that work, but it was very scattershot. We tried to sort of intentionally organize that work, and we created a Center for SDOH Innovation about 3 years ago. And one of the initiatives under that was this SDOH benchmark assessment. We did it in 2020, and we developed this center. I should give some props to Spring Street Exchange. They're a fantastic partner. They're located in Boston, Massachusetts. They have a lot of really great expertise on social drivers, and so we've been working with them. We worked together to develop this benchmark assessment. And really, the plans that participated, they get an individual report, they got benchmarked, and then ACAP itself got some synthesized results that helps us drive some of our programming and see where the needs of our plans are. So the next slide, and I think they're actually in the agenda, there is a link to the full set of, I just dropped it in. It's the full set of the benchmark assessments that we're making public. What we're going to talk about today is a limited number of those. Some caveats to this. It was only 20 of our 80 plans at the time that participated. So it's a subset. Everything's de-identified. The 2020 group and the 2023 group were different plans. Some were the same, but some were different. So you have to be a little careful about trending, but you can see sort of writ large some of the trends that were happening. Next slide. So let's jump into the results. So I'll do a couple sort of broader picture results and then get down into some real nitty gritty with some of the food insecurity issues that they're trying to address. So one big question we asked is, what was your organization's current commitment to addressing health-related social needs compared to 2 years ago? And thankfully, everybody's moving in the right direction. We have 75% of the respondents indicated that there was a substantial increase in prioritizing health-related social needs from 2 years ago. So that's sort of the big takeaway from this slide. And there's a lot more stuff on these slides that I'm not going to go into detail, but I'm happy to answer questions on. Next slide is sort of, we asked some structural questions, an internal structure, like who's addressing health-related social needs in your plan, and 75% said they have cross-functional teams, which was a 10%. It's actually should have been a 10 percentage point increase. It's a little typo there, but really just demonstrates that addressing social needs is a team sport. And the next slide really tried to drill down into that. What departments were really working on this? Not surprising, the clinical folks, the quality folks, that was really an initial driver. They trying to address these needs. They know that those impact members' health. Plus, that's where you get into some of the ROI, some of the measuring the impact shows up in some of these clinical measures, quality measures. But then you can see as you go along this graph that there's additional departments that are involved in that. One place I would point out an opportunity is that there's probably only about half of these plans, or I can't count them right now, have community engagement department working with them. And I think that's a real big opportunity for our plans, at least, to reach out or have their departments be more involved with the work that they're doing. Providers, customers, members, that's not too surprising, but it's a little surprising that some plans aren't even using those departments. Next slide is a kind of a complicated slide. It has to do with medical loss ratio. And this has to do with rates that you get paid. And this kind of goes back to what Katie was talking about, some of the state authorities. The state authorities are interesting because not only do they tell you what services you can provide, and some might not have been original Medicaid services. That's why you get waivers to offer them. And a lot of these social needs services fall into those categories. But they also dictate how you get paid for those services, or whether you get paid for providing those services. So sometimes those don't always match up very well either. So this is a complicated and nuanced question. It was really hard for us to get good data out of this, because basically what it comes down to is that some pieces, some activities, some services you get paid for and get counted in your medical side, your quality side, and some don't. Some of it gets counted only in your administrative costs, or it doesn't get counted at all. They pay for them out of reserves. That's not very sustainable in the long run, so that's a challenge. But you can see that there's an increase here, that 77% of the respondents say that always or sometimes they include expenditures as medical costs in their MLR calculations. But again, that's a complicated question and a complicated answer. Next slide. One of the first steps, of course, in understanding members' needs is screening for them. So really just want to point out that this is another opportunity, I feel. If you look at the bottom of the chart and look at the last two rows, 45% of respondents say that they screened 51% of their members or more. Again, that there seems like there could be some opportunity there to be screening more of their members, but that is a challenge as well. Just getting the resources to do that, being able to touch all the members at any given time. The next slide sort of harkens back to what Katie was also talking about, evaluating impact. So we asked questions about how their plans analyze social risk factors and other demographic factors that impact utilization and cost of care. You can see there was actually a big jump from 2020 to 2023, with 65% saying that they are doing that. So it's almost doubled. But this is really a critical piece and a challenging piece to be able to measure something that, a lot of them, as you all know this, a lot of these are upfront short-term costs, and the benefits are long-term, stretched out. They don't always accrue to the plan, the wrong pocket solution, problem, all those sorts of things. Next slide, a little bit more granular. What social risks do they include? And you can see that transportation, housing, and food insecurity were at the top of the list, and food insecurity not far behind the two top ones. Next slide. Basically asked about the sources of information and how they rank those sources of information in importance. It was really fantastic to see that 100% of the respondents said that they listen to their members, as well as they listen to their partnerships and services available. Basically, that's their CBOs, their other partners in the community, and then they look at the data that they have. But it's interesting that actually what drives it is their mission, is the driving force behind investing in social drivers, to address social drivers. And what's also interesting is what doesn't drive it is evidence-based interventions, which again, another opportunity. I think the more and more opportunities to provide sort of information about what works and what doesn't work. That's what I hear all the time. Where should we invest our money? What works? What doesn't work? Next slide. Just asked like how long they've been investing in these various domains. And you can see for the fourth column, I guess, on food and nutrition, we have a number of plans that have been at this for over 10 years, and then some that are pretty new. But what's good, what I like about this is like almost all the plans are really focused on food insecurity. Again, a lot of this work was very grown organically. It's like they saw a need for a population here, a population there, and now there's much more intentional strategies, frameworks, data collection efforts. All those things are happening and much more intentionally now. Next slide. I'm running out of time. What percent of your organization's full membership is engaged in any of your programs? You can see sort of the different levels here in food and nutrition. Is actually pretty well engaged. Their membership is pretty well engaged in those services. But this is also a challenge to understand why they aren't. Is it that they don't need those services? Is it that they haven't been screened? They haven't been touched in a very, by somebody in the plan? They're not getting the appropriate outreach, those sorts of things. So but so again, another opportunity. And one of the things that they mentioned is that there's an inability to find partners to deliver those services, as well as a lack of the CBO capacity. And that's what the next slide really shows: the biggest challenges in your organization in starting the programs, as well as maintaining them. And you can see some of the reasons given, or it's the limited CBO capacity. And I guess the lack of funding is another big driver as well. And I think the last slide I have digs a little deeper on the challenges of working with CBO partners. And basically the capacity issue is the number one reason why they said it's a challenge. I do think that the contracting issue, I was actually surprised that wasn't as high on this survey, because that's what I hear a lot. It's really a challenge to involve all their legal folks and the data security folks and governance folks and everybody else to get these contracts written. And that's a big challenge that I've heard. It's not quite as reflected here in the survey. So with that, there's a ton more information in the full slide deck that's available on our website, but I really appreciate being able to share some of those results with you. And I think I'm turning this and happy to answer questions in the chat. I haven't been able to look at them now, and I know we'll be in a breakout room, but I'm turning it over to Alex Ashbrook now.
Thanks so much, Enrique. I'm Alex Ashbrook. I work at the Food Research and Action Center, affectionately known as FRAC. FRAC works to end poverty-related hunger in the United States and improve the nutrition health and well-being of families struggling to put food on the table. And we do so through partnerships like this one. We're on the steering committee, through research and advocacy, and by advancing bold and equitable policy ideas. So we're thrilled to be here to share a bit on our report that we did. It really resonated with many things that Enrique said, but in particular, I liked how you said addressing social needs is a team sport. So I'm going to look at the team members who are the anti-hunger community. And what FRAC has always positioned our view of food as medicine as, we want to, if you're looking at the pyramid, we want to make sure that the bottom level of the pyramid is addressed. And this is part of the philosophy of this Medicaid Food Security Coalition. What are we doing to ensure that people who are eligible are connected to the federal nutrition programs, most notably WIC and SNAP, because we have reams and reams of evidence that these programs improve health. And we also know that most of these programs are entitlement programs, and they're available to anyone across the country who's eligible. So what we wanted to do in this report was to learn more about how anti-hunger groups were working in concert, in partnership with healthcare providers, to connect people to federal nutrition programs, especially SNAP and WIC, as well as other food and nutrition resources. And what were the opportunities and what were the barriers? And I see a few people, specifically Project Bread, who was surveyed in this report, and there's a nice case study about them. One of the participants lifted up, who was interviewed for this report, just going back quickly on the methodology. We sent out surveys. We had about 56 organizations that identified as anti-hunger groups complete the surveys, and then we did a handful of interviews. And one of the respondents put it this way: food is only medicine when it's accessible to all. The federal nutrition programs reach people in all avenues of life, from urban to rural to tribal communities, and from babies to seniors. Medicine only works when people have access to it. So what we found in this report, and you can go to the next slide deck, next slide, won't surprise many of you on this call, but we saw a great response in terms of the work folks were doing. And the vast majority of people surveyed were connecting people to SNAP and WIC. 82% worked on SNAP, 68% worked on emergency food, and 57% on WIC. And what was also noteworthy was that many providers partnered with federally qualified healthcare centers or community health centers, which are intended in many ways to serve people on Medicaid and low income, families with low incomes, but also many of them partner with private practice. So one of the things we've been trying to really get out in the universe is that just because you don't have, a significant number of patients who are on Medicaid, it doesn't mean that you don't have patients who are struggling with food insecurity. And the anti-hunger community is reaching out to providers who sometimes may not even recognize that there's a role that these programs can play. We found out that there was no one size fits all in terms of how people were partnering with healthcare providers. Some were doing warm referrals, some were visiting people on site, and then others were actually training the healthcare providers so that they could take over work to connect people to programs like SNAP and WIC. The top challenge was capacity and funding, but we also found that that the anti-hunger groups were actually getting funding from either the healthcare partners themselves or community-based funding sources and other types of foundations. There was great enthusiasm for this work, and I only had 5 minutes. I want to wrap up, but we'll be talking about more about this report when when we have the breakout groups, but we'll also be looking at it in an upcoming Hunger Vital Sign Community of Practice meeting on September 20th. We'll send some information and out to this to pass on to many of you. And that's a great segue for me to turn it over to Richard Sheard, who's with Children's Health Watch, and Children's Health Watch co-convenes the Hunger Vital Sign Community of Practice. I look forward to hearing your questions and ideas. Thanks very much.
Thank you so much, Alex. It's great to join you all. I'm Rich Sheward from Children's Health Watch, based at Boston Medical Center, and a member of the steering committee for the Medicaid Food Security Network. And I'm here to update you on a recent policy development that I think you'll all be interested in learning about. The U.S. Preventive Services Task Force and their recently released draft recommendation statement on food insecurity screening. I know that was included in the agenda. I'm going to put a link in the chat to that recommendation so you can all read the details yourself. But just to provide some context and overview, the Preventive Services Task Force is an independent group of medical experts that review scientific evidence to make recommendations about preventive health services. So these are kinds of tests and screenings and interventions your doctor might offer you to prevent diseases or catch them early. And so their main job is to figure out the benefits of a preventive service and do they outweigh the potential harms. And they do this by carefully examining all the available research, and then their recommendations help doctors decide what preventive services to offer their patients. So to give you an idea, some of their other recommendations are screening for breast cancer in women ages 50 to 74 years old, screening for colorectal cancer in adults ages 45 to 75 years, and screening for depression in adults, including pregnant and postpartum women. So, these are things that I think you're all familiar with. Some of you may have been asked or screened for these by your doctor. So the great thing about the Preventive Services Task Force is when they make a recommendation, it's pretty widely adopted. And their recommendations are graded from an A, which is strongly recommended, to a D, which they recommend against. In that case, you would assume that the potential harms certainly outweigh the benefits. There's also the grade I, which means there isn't enough evidence to make a recommendation either way. So with that context in mind, let's turn to the food insecurity recommendation that they recently released. So now they did this in recognition that identifying and addressing patients' social conditions is becoming a focus of many national efforts to reduce health inequities and improve overall health and well-being. We all know that. That's why we're here on this call today. So the Preventive Services Task Force decided to look at social risk factors, and they chose to start with the domain that has the most available evidence, which is food security. In this case, they're looking at whether doctors should routinely screen patients for food insecurity. Now, in their recommendation, this draft recommendation, they gave it an I grade, which means that they don't have enough evidence to say whether doctors should or shouldn't screen for food insecurity. So this doesn't mean, and they're not saying that it's not important, it's just that we need more research to understand if screening in healthcare settings leads to better health outcomes. So what are the implications of this? For doctors, it should not be interpreted as a deterrent to screening. In fact, there are still a number of requirements and recommendations from other medical organizations on the importance of screening for food insecurity. And what I'll do here is put a link into the chat that the Hunger Vital Sign National Community Practice published on all of those quality and standard measures that include recommending screening for food insecurity by CMS, the Joint Commission, other organizations. There's a track record of this as well, that there are certain tests and screeners that aren't recommended by the Preventive Services Task Force, but are recommended by the American Academy of Pediatrics, for instance, and that many pediatricians utilize. What it means for researchers is that this highlights the need for more studies on how screening for food insecurity in healthcare settings affects health outcomes. The evidence for screening is very strong. It's that the evidence that the screening and then what happens next, that intervention, affects health outcomes. And so, especially for policymakers, it suggests that addressing food insecurity may require broader approach, just beyond just the healthcare system. And I think that gets at some of the points that Alex made previously about the federal nutrition program and the safety net that we have at our disposal. So I'll just close with a few key reasons behind this statement and things to take away. I think there is a lot of complexity in addressing social risk factors, especially in a primary care setting, because these don't, food insecurity doesn't exist in isolation. It often intersects and interconnect with housing instability, transportation issues, other health-related social needs. There's challenges in exploring how to incorporate social needs into this recommendation process. Screening for colorectal cancer or breast cancer, it's a very different approach and a different animal than screening for social needs. And so there's limitations in the way that this preventive services task force approaches it. And so they're looking at their methods and their framework going forward. So this is not the end. If anything, it's really just another step along the road. And we're going to have a breakout discussion about this. So I'm happy to dig deeper into it with you all. But with that, I will turn it over to Carl and Aurora for another update from the field. So thank you all very much.
Right. Thank you. Can I get permission to screen share, please? Great. Thank you. Bring it up. Realize that I'm the only thing standing between us and our breakouts here. And want to recognize my colleague Aurora Grant Wingate, who's mainly going to be joining us to partner on in the breakout session. There we go. But I'm going to go through these slides. Can you see my slides?
Yes.
Okay. So real quickly, there's a lot more we can go into all of this, but first of all, where you see community health workers in this space of food security, food insecurity, that obviously CHW is involved in many of the referrals to resources related to food and nutrition. They're engaged directly in nutrition education, and sometimes in specifics like opportunities for modification of traditional recipes or supermarket shopping tours, etc. They are involved in direct service. I've heard from many CHWs who are actually involved in delivering boxes from food pantries and from meals programs. Since they are in touch with these same individuals for other reasons. And then, of course, they can be and should be probably more frequently involved in individual and community advocacy in this domain. So most of the work, Medicaid work with CHWs is funded under the authority of a state plan amendment. So I just want to review quickly what that process looks like. In some cases, they need enabling legislation, but they oftentimes start with a study bill, which is a little bit easier to get through the legislature. It's really important that, and Aurora will help me reinforce this, important to support a strong CHW leadership role in program decisions. There are many people, other stakeholders, but certainly state officials who need a fair amount of education in terms of the true nature of the work of CHWs. The SPA plan often has to be approved by a health commissioner or state board of health, and there will be public comment period required in states with major tribal presence. There's also a tribal consultation process. And there is a wonderful summary. You will be getting these slides, a brief summary of the components of a state plan amendment, which is very helpful to that. And we are doing frequently presentations on this. We're about to publish something, which I'll mention, about the components of a Medicaid state plan amendment. There's a cover letter, of course. There's a standard application form, a one-page form. And then there's an attachment or addendum with details of the SPA language, which must also include community health worker qualifications. Anytime they're authorizing services by non-licensed personnel, they do have this requirement. It does not, however, require that the state have certification of individual CHWs. So the Envision Equity, which is one of the work groups I'm working with, is about to release a sustainability toolkit developed for the CDC, which will include a template for creation of state plan amendment. But I do want to highlight, because of the nature of the work of the CHWs, why it's so important that the state engage with CHWs in designing the state plan amendment. Their choices in a payment program can have a profound effect on the work of CHWs. I'll go through this real quickly, but this is meant as a rationale for why the state really needs CHW leadership in designing these benefits, and why the CHWs see their own self-interest in being at the table. Obviously, what services will be covered. The recent state plan amendments have several buckets of services, but the range of services is very wide. It is far more than just referral or education. It covers a lot of stuff. It is really, some states will limit the amount of reimbursable time CHW can spend with a client, what the rate of pay. It's important to remember that the billing rate for CHW services includes a lot of other costs that are not relevant to other types of personnel. Things like travel time and the amount of time an individual CHW spends developing a relationship with the individual, which is really not relevant in many other provider relationships with individuals. In what settings we advocate that Medicaid pay for CHW services, where basically wherever the recipient is, a community setting, clinic setting, home visiting is very important as well. And then who may recommend or order CHW services, who must supervise them. These are all crucial decisions. And then lastly, and this spills over into a number of the other conversations we're having on this call, is how will community-based organizations participate in Medicaid payment? Medicaid is not a great fit for a lot of CBOs, and they will find Medicaid billing in particular to be of a significant burden. But there are states who are trying spending a lot of resources on intensive TA for community-based organizations. And they are encouraging and supporting conventional Medicaid providers, clinical providers, to partner with CBOs for specifically for the employment of the community health worker. So I mentioned the range of services covered. Rhode Island is a good, fairly current example. This is from a couple of years ago, but the buckets they've chosen include health promotion and coaching, which includes a lot of interesting stuff that we've been talking about in terms of screening and assessment, for example, and action planning with the individual or family. What are the priorities of that individual or family? How do they create plans together to address what those priorities are? It isn't necessarily the top programmatic priority of the employing organization. It's what the family wants that is important. And of course, observation of living situation, which can affect a lot of things related to service provision. And of course, many people are familiar with the health education role of community health workers. Generally under Medicaid, they're required to follow established protocols or curricula for health education, which of course can be developed by the employing organization. Doesn't have to be from some sort of national authority. And then navigation and resource coordination, which is extremely important as a larger role, which it provides other benefits to payers, including things like patient engagement and adherence to treatment plan, that sort of thing. And care planning. We of course acknowledge that the CHW is a non-licensed individual, cannot create or authorize a plan of care in a clinical sense, but they are very often parts of a care team that do the care planning as well as executing that plan. Engaging CBOs is a very important area, and Most of the states currently, they're paying for CHWs and paying fee for service, which is an awkward model, to say the least. So these CBOs, particularly the smaller ones, are not accustomed to submitting claims to a payer. And so this idea of submitting claims to Medicaid is a new one. And a bunch of states are taking extraordinary steps to make the claims process less burdensome for CBOs. And there are states that have created whole categories of billing providers just to include folks who are not used to submitting claims to Medicaid. The administrative burden can still be discouraging for a lot of them. So there are some entities, particularly in a state with a long experience in this, like Minnesota, where their organizations are set up to be not just third-party billers, but the ability to generate orders for service and things like that to support the CBOs in their role. The states are actively encouraging medical providers to partner with CBOs. There are a lot of advantages we can talk about in the breakout, advantages to medical providers partnering with CBOs as the actual employer of community health workers due to their strong connections with the community itself, which is really crucial. Some folks will, I'm sure, very quickly point out there are challenges with FQHCs in general. An encounter with a community health worker alone does not count as a billable encounter under prospective payment system in most states, but there are at least 5 states that I'm aware of that have come up with some really creative approaches to this problem because we need for the FQHCs to be fully participating in all of what we're talking about here. And some states are, I mentioned this briefly, but others, particularly California, Rhode Island, South Dakota, are proactively working to build CBO capacity to participate in Medicaid, which is, I can't say enough about how important that is. Some other resources, this will be in the slides that you get, but state policies from NASHP, briefing paper from the National Association of CHWs on state level financing strategies. And I'm sure familiar with these other documents. Employer level financial sustainability strategies, very important concept for the organizations participating in this. And then some specific, we've had these concepts mentioned earlier in the call. I need to turn this over, but I want to make sure before we close out and go to the breakouts. Aurora, are there other sort of key points that you would like to reinforce for the full group before we go to the breakouts?
Thank you so much, Carl. That was a great presentation. I will not take up too much time. I'm just letting folks know that NACHWA is a resource for you. If you do need help ever connecting with your state level CHW network, who may be working on some of those issues, as well as I dropped in the chat, we now have a bi-weekly national CHW policy working group. So if you're interested in getting some more consistent updates or sharing what you're working on, that is a place that has dozens of really great subject matter experts working on these exact topics around the country. But with that, I will hand it back to our facilitators. Thank you so much for having us.
Thank you, everyone. Thank you, Carl. Thank you, Aurora, for that presentation, and also to Rich, Alex, Enrique, and Katie. We're excited to dig into the discussions a little bit more into our breakout rooms. So we will spend, just in an interest of time, around 25 minutes in breakout rooms. Each group will have a facilitator and note taker as seen on the screen. And the breakout rooms are really times for you guys to kind of dig in a little bit more with the facilitators, any questions or comments that you may have or want to build on. And we will want to spend some intentional time getting to know each other, but I will open the breakout rooms. Participants, please self-select which room you would like to go in based off of your interests. You're welcome to bounce around as well. Just please consider that if one breakout room has a ton of participants, try maybe going to another one so that we can keep these breakout rooms small and intimate. So I will open those up right now. And at the bottom of your screen, you can select which breakout room you are either assigned to or would like to join.
I don't see it. Are other folks seeing it? I wonder if it's me.
I'm not seeing it.
I'm
I don't
sorry
see it
about
either.
that.
I'm not either.
Oh, it just popped up for me.
Okay.
Is everyone else seeing it? If you somehow I clicked on the three dots that said more, and then all of a sudden it said join a breakout room.
All right. Thank you, Catherine. Thanks, guys, for your patience and troubleshooting. If others are having trouble getting into breakout rooms, please let me know and I can place you in the one of your choice. Welcome back, everyone. Sorry to cut your conversation short. As we're waiting for folks to come back into the breakout rooms, feel free to chat. If there's any highlights from your breakout room discussion, anything you learned, if there's any way that us at the Medicaid Food Security Network can support you in connecting with other folks on the call, please let us know. We almost have everyone back.
We got confused. We didn't know you had to click leave room. So several of us were just like, when are we gonna come back? So I wonder if other people also are bad at following directions, like me.
It's okay. It gives you a 60-second window for you to come back.
Oh yeah, I was just like hanging out
No
until
worries.
someone
We
pointed
were
out to me that you
totally
have to
hanging out.
actually leave.
We were just chilling in there thinking it was going to happen naturally for us.
Yeah, that's where I was. I was like, what's happening?
Well, always a good reminder for next time. We'll make sure to do that. Well, I think that we have most people back. I will pass it to Colleen to wrap us up.
Sorry, I too was navigating. Do we have time for quick share outs from the groups or not?
We have a
High
minute.
level takeaways? Elena, do we have time for that?
We have 1 minute.
Oh, we have 1 minute. Well, hopefully we can post some of these. We had some great ideas, some really nice summary things from our breakout, and I want to just thank everybody for attending and participating in such an informative session today. We had so much rich content offered by our guest speakers. And I'm going to echo what Catherine is saying in the chat. Come back to our next meeting. We'll have our next quarterly meeting will be in January. We'll have the news digest in between now and then in November. We'll be able to share a lot more. I also wanted to just quickly share, early November, remember that childhood hunger is a bipartisan issue. And September 17th is National Get Out the Vote date. So I am going to drop in our toolkit on and our website, the No Kid Hungry Get Out the Vote. So a little extra there. If you have remaining questions or comments, please reach out to Elena Reese. Thank you, Elena, for helping us navigate today. Thank you everyone for your participation and look forward to seeing you online at the website and then in person again back in January. Thanks everyone. Have a great day.
Thank you. Kids can't vote, but you can. I love that. Okay.